Good afternoon, everyone. This is 2C, Community Members in Action in COVID-19 Response. I'm Dr. Linda Bain Frizzell, an Associate Professor of the School of Public Health, University of Minnesota. I'm also a governing board member of the Minneapolis Indian Health Board. I'm Eastern Cherokee and Lakota, and quite honored to be asked to to be your moderator. I teach 6 classes at the University of Minnesota in American Indian Health and Wellness, and including our new scholarship program for our administrative classes that's available to American Indians. I wanted to provide you with a few housekeeping items before we get started. If you hold a CHES or an MCHES status and do not submit your ID during registration, please submit your name and ID number to virtualsym at ceus@minorityhealth.hhs.gov to receive your credits no later than tomorrow, September 18th, using the same email address used to register for the symposium. All virtual symposium attendees have been placed on mute. Please post your questions through the Q&A corner at the top of the screen for responses from the speakers. Due to limited time, not all questions will be answered during the symposium. Finally, we encourage you to answer the 2-question survey that will appear on your screen following the presentation. It is my honor to introduce Ala Stanford, who is the co-founder of the Black Doctors COVID-19 Consortium. Dr. Stanford is a practicing physician for over 20 years, is board certified by the American Surgery in both pediatric and adult general surgery and healthcare, and a healthcare advocate. She is the founder of Black Doctors COVID-19 Consortium. The consortium was formed in response to a disproportionate number of African Americans being diagnosed and dying from COVID virus in Philadelphia, Pennsylvania, and a lack of swift intervention to mitigate disease spread. The mission consortium is to educate, provide advocacy, and barrier-free coronavirus testing in an effort to decrease the morbidity and mortality associated with the disease. Her research in basic science, and clinical research, and public health have been published in peer-reviewed medical journals. Dr. Stanford also serves as a medical correspondent. Our next presenter will be Sudarshan Pai-Kurel, and sorry if I really slaughtered the name, who is the Executive Director of the Bhutanese Community of Central Ohio. Mr. Pai-Kurel is the member of the Bhutanese community in Columbus, and he is a former refugee from Bhutan. Mr. Pai-Kurel is the Executive Director of the Bhutanese Community of Central Ohio and community leader and advocate for social justice. He is also the founder of the Bhutanese American Student Organization, which is a nonprofit higher education advocacy organization, and founder and managing director of the Jairan American Nepal newspaper published in Columbus, Ohio. The objective that we have for this presentation is to have this community members in action in COVID response is to highlight state and local efforts to encourage and involve community leaders and members in assessment of community needs and COVID-19 response. So with that, welcome everyone, and let's begin.
Hello, my name is Dr. Ala Stanford, and I'm a pediatric surgeon and founder of the Black Doctors COVID-19 Consortium. In April, specifically April 3rd of 2020, a report came out in the Philadelphia Tribune that African Americans were dying and being diagnosed with coronavirus at a rate greater than any other group in the city of 1.6 million. And because there's no cure, there's only supportive management, there is no vaccine currently, the only thing in our armamentarium was to get tested. But yet there were these barriers that existed that was precluding residents, particularly Black residents, from getting tested. And this came out from Drexel University stating that if you were poorer, you were 6 times more likely not to be able to get a test because most of the testing were in high income neighborhoods. And so I already had a consulting and health advocacy firm. This is our Black Doctors website, but then I, in essence, went to social media and I said, if you need a test and you're having issues with access, we are offering no cost, barrier-free testing. Please register on our website. This is what the registration looked like. And on the first day, we, in essence, went out to every person who had registered, door to door, and we tested them for coronavirus. And the funds to get started came from my personal bank account. The testing kits came from colleagues who were primary care physicians that were not using them at the time. And then I advocated for the Black community and said that these tests aren't available with LabCorp. And they were able to, as I had a LabCorp account as a private practitioner, to provide testing kits for me. And as we used those testing kits, they were replenished. So on this particular first day, April 16th, which incidentally was the day of peak tests peak diseases of coronavirus in Pennsylvania, we tested. The first day we tested 12 people, the second day 150, and by the third day we were testing 400 people. And this picture, you can see that many are seated. It was April, so it was still cold, and all these folks were lined up in cars to get tested for coronavirus. So why are these rates higher in African American communities? And many will tell you it's because of pre-existing conditions. I respectfully disagree that that is the primary reason, because as my friends and colleagues called me, yes, they were African American, but they were educated with insurance and they were being turned away. So it pointed more towards the systemic injustice, racism, implicit bias of healthcare workers. The APM Research Lab published something very timely about the color of coronavirus, looking at deaths by race and ethnicity. And at the time of this presentation, African Americans are dying at a rate of 80 per 100,000, where white Americans 36 per 100,000. And depending on who you study, the information as depicted here on this graph, you can see the number increased, the highest death tolls from COVID-19 are in the Black population. And here are the dates from April through August. So everyone talks about these social determinants of health: economic stability, the neighborhood, your education, community and social context, and your access to the healthcare system. And I don't deny that you need access in order to get a test. You needed a primary care doctor. You needed a referral to get your test. You needed health insurance. But even with those who were educated and had those things, once they came to the healthcare system, sometimes they couldn't gain access, and there was no empathy once they came in the front door. So here, as these people are seated, some of them needed assistance filling out the paperwork. We helped them with that. So education, it didn't matter your educational level. We had the access. Healthcare providers, we were purposeful about naming the organization the Black Doctors COVID-19 Consortium because evidence has shown that Black providers with Black patients have better healthcare outcomes. And we wanted to demonstrate that and also have a certain level of trust. Access, our doors were wide open for them. Medical bills, there were no medical bills. There were no out-of-pocket costs for people coming for our tests. For those who were uninsured at the time, I had LabCorp bill me. Transportation, we were in their neighborhoods. So all they had to do was be coming home or come out their front door, and we were right there. We engaged the community to help us let others know in the neighborhood that we were coming. Every person who was there, no one was getting paid when we started out in April. They were there because we wanted to be present. For our Latinx and other communities, we had translators to help. We were going to the hard-hit communities. And now we've tested over 10,000 people where over 90% is African American. That data set, invaluable.
And I'm here to get tested, and I just want to say it makes us so proud when our doctors that look more like us get together and to service us. It makes us feel so proud because other places we've been going to, we've been getting turned away because we didn't have the symptoms, or we have the symptoms and no one wants to service us. So I'm just grateful that the Black doctors here are looking after us. Thank you so much for all you do and your hard work.
Well, you asked a question about it. I felt more comfortable coming to my people. And basically what I'm saying is, they're probably going to come across something that someone else would not notice. And I'm not trying to be funny about it, but I feel more comfortable with my own people. Plain and simple.
On one hand, it was a challenge, or it has been a challenge as we're in these current times. But it was also refreshing to see MIT and the Brookings Institute publish this data disputing that social determinants of health are the primary reason why African Americans have a poorer outcome. Because in essence, we're blaming the patient. We're saying because you have poorly controlled diabetes, you're more likely to die or contract the disease. But no. These articles showed evidence-based work to demonstrate that even when you control for variables about obesity, nutrition, health insurance, that the statistically significant variable is being Black. And even goes so far as to state that for my age group, for example, that I am 6 times more likely to die from coronavirus than someone who is 10 years older than me and white. And so coronavirus is insidiously taking out young, productive African Americans in society. And when by the time you present to the doctor, you are hypoxic, you don't have enough air, you're breathing hard, you have an infection spread through your body into all your organs. There's not much supportive management that's going to reverse what has happened when the disease has progressed so long. And so for African Americans, that is the majority of why so many lives were lost at such disproportionate rates, because the doors were not open for us. And when they were open, we were already past the point of no return. With the murder of George Floyd, the testing, the environment was so tense. And here we were testing the police and testing other entities, and there was so much angst, but yet and still we were there testing. We didn't cancel because of protests nor weather, because the need was so great. From MIT, Sloan showed that the correlations of coronavirus and death rates, that socioeconomic status and race, yes, they play a role, but not as much as people weighed for obesity, nutrition, diabetes. Those were not the primary reasons and causes. And when this data began to come out, it's for healthcare providers to see what can we do and what are we doing? What should we be doing? So there's some short-term and there's some long-term. One, barrier-free testing. And when you contact trace, you must have a safe and clean environment for someone to isolate or be quarantined. As healthcare providers, we must acknowledge our implicit bias. We all have it, but you can't just know it. You have to do something about it so that that delivery that you're providing to a patient changes, so they feel better about the interaction they've had with you. The historical experiences with African Americans in this country cannot be discounted. That in 1800s, slave women were used for gynecological experiments and surgeries without anesthesia, without their consent, over and over again until they could perfect it and then perform it on white women. That was in the 1800s. And then you, of course, have Tuskegee, and then Holmesburg Prison, and then Immortal Cells of Henrietta Lack, and now coronavirus. And here we try to introduce a vaccine. You must be empathetic to those historical experiences. These are our short-term measures. Long-term, this is the health commissioner of the city of Philadelphia. And as he acknowledged and recognized and funded us for at least 6 months with a 7-figure grant to help us continue the work we were doing. But it didn't just stop there. It was now myself and the health commissioner saying to these hospitals that received CARES Act funding, we need to be able to provide testing barrier-free 7 days a week for anyone who needs to be tested, with nighttime hours and weekend hours, so those face-front employees that are serving the public and keeping the country running have an opportunity to get a test. We know that African American patients do better when cared for by Black doctors, but yet they only represent 4.8%. This is actually higher than the actual number from the American Medical Association. That was the same percentage 23 years ago when I graduated from medical school. There are competent, qualified, educated, poised and ready young Black people that are ready to be doctors, but because of systemic injustice and racism have not been enrolled. The majority of Black doctors come out of historically Black colleges and universities. They cannot shoulder that alone. Just as we have incentives and bonuses for productivity, there should be incentives and penalties when you don't present preventive management to vulnerable groups. It's a multi-layered approach and a concerted effort that we get to better healthcare outcomes, not just with coronavirus, but moving forward. As I mentioned, I'm a pediatric surgeon, and this was this summer when I was performing an operation, and the intern, the visiting student, and the nurse were all African American. That happens to me maybe once a year, and I wanted to capture that photo so you can see what I mean. It's not lost on me that there are not doctors and nurses who look like me every day when I come to work. I don't have that same comfort that others may have. There is a paucity of Black healthcare professionals, and that is leading to the poor health outcomes in our country. The Center for Health Equity, which is a huge push that's needed in Philadelphia, is my ultimate goal. We are not just trying to put a Band-Aid on coronavirus, but with the number of patients we've touched, with different corporations and entities that are supporting us, we want to continue this beyond the pandemic and improve these outcomes. This example from Nationwide Children's Hospital just gives you, it points out about these healthcare disparities. That postoperatively, children, healthy children, black and white, one next to the other, healthy kids, basic operation. Why do black children have more surgical complications, more deaths, and more adverse reactions than white children? These are healthy kids. It's not genetic. That has to do with who is providing the care. We must do better. Healthcare workers must be held accountable. Even among healthy children, being African American is strongly associated with a higher risk of postoperative complications. This is out of the American Academy of Pediatrics. Access, empathy, and action. Those are the mantra of the Black Doctors COVID-19 Consortium. I believe it's why we've been successful, but we have so much more work to do. This was in the streets of Philadelphia. Myself, my pastor, Pastor Mitchell, and you can see the diversity of our group. Yes, we are focusing on the hard-hit African American and Latinx communities, but the people who are serving these communities come from all different ethnic backgrounds, and we welcome them. I appreciate your time in listening. The Black Doctors COVID-19 Consortium was formed out of necessity because what needed to be happening in our communities was not happening. And from a group of individuals that wanted to let the community know that we value your life, and that's why we're here. And as long as we have sustainable support, we will remain present and serve these individuals. Next is with flu vaccines, and after that will be transparency with the COVID vaccine. We are poised and ready. And so I hope coming away from these sessions, you see what as healthcare professionals we can do to be part of the solution. And I'm grateful for the city of Philadelphia for the trust that they have given to us on this journey. Thank you so much for your time.
Hello, everyone. My name is Sudarshan Peckrell. I am with Witness Community of Central Ohio. I am the executive director for the last 6-7 years with the agency. And so today I'm going to talk about the BRAVE project, which stands for Witness Response Assistance Volunteer Effort. We started BRAVE project at the end of the March when COVID was coming to Columbus in a sense. And we had no other tools to address this issue. We serve, through BCCU, we serve mostly South Asian community and primarily Bhutanese refugee, Bhutanese Nepali refugee, often we call. And in my community, the education level is very low. People are coming from refugee camp immediately, and they have been in the U.S. for average 6 years, 7 years. So the amount of, the English competency is very low overall. And when the message about COVID or coronavirus was coming, we have only one option, that was to provide information as much as we can. And we begin with that one. We were creating flyers, we are creating videos, but people weren't taking it seriously because there are a couple of reasons. One, people have been through a lot, right? They were kicked out of their country. They spent years in the refugee camp. And in the refugee camp, the situation wasn't that great. There was flood, there was fire. Every season, they were pushed to death. And people had become insensitive to this kind of, news about death and diseases because they had seen a lot. In refugee camp, they would experience a lot of, common death because of diarrhea, cholera, malaria, and the list goes on and on, even smallpox and things like that. So, and they had seen this over and over. almost for 2 decades, and they have become very insensitive. So when we, not insensitive in a sense that they were not sensitive enough, but I think they had gone to the level that they were only thinking about surviving in terms of food and safety and security. And these are newly resettled refugee population, and studies had shown that Bhutanese refugees have a high level of trauma and anxiety. So I have been part of the research. I work with the professor at Ohio State University, and I had this clear understanding that people really need a close sort of a guidelines or guidance to be able to get through this COVID. And in the meantime, I was keeping my eye on how the COVID was progressing in China and in Spain and in Italy and things like that, even in New York at the time. And I had some sense, but luckily I had friends who were physicians and they speak Nepali. They were my friend. Two of my very close friends, one of them is a scientist. He is an immunologist at Nationwide Children's Hospital, and other was a postdoc fellow, and he actually was doing research on virus. And I had this, amazing amount of opportunity to talk to them, how this virus work, what are possible scenarios. Although they weren't that clear, but we were doing every single day sort of brainstorming what it is and trying to decipher how this is going to impact not only my community but every community. That is the virus side. The other side is how politically and socially this virus was impacting other communities. And at that time, I felt that it was way early in April that this is going to impact minority community like refugees, LEP communities, limited English proficiency community. We need to do something because why I was saying that to my friend was because communication was the key here. If they won't be able to understand what is being aired in the television and radios, there is a big communication gap. And obviously in refugee communities, there is already a big communication gap. So we have to step in. That was my feeling. And then I think it was March 27th that we launched a Brave project. After doing a thorough brainstorming for 2 weeks, I had to close down my office. And then it's not a big office. We are just 5 staff, but I had volunteers and very well-educated friends who are professors or researchers themselves. And with their guidelines, we were able to come up with the Brave model. If you can see in the first page that Brave ground, Brave nurses, Brave will, and so on and so forth. It moves forward. So I work with two professors at Ohio State University. One of them teaches social work, Arati Maliku, and the other one teaches ecology, environment, and education. He's Professor Subedi. And then Professor Maliku actually helped me design this model. And, we are putting pieces together. How do we address this COVID without exposing any one of our staff at that time? So the idea is without exposing staff, how we can do it. And then we come up with this model. I talked to my two physician friends, and this looks good. Let's jump into it. Let's try to launch our own rescue model here because every community needs to do that. This is not something that the government will be able to come down and work. This is a complicated process. So every person who is able, who can speak English, and who has time need to jump in. Otherwise, this virus is going to be very, very dangerous. At that time, it is dangerous, but we were anticipating way more dangerous than what it is now. So with that, we come up with this model, and then and we begin to implement it. We implement that in Columbus for a week, and initially we thought that we would implement in Columbus only, and the result turned out to be very amazing because we had these people working in 5 different groups. Now, Brave Ground, Brave Nurses, and Brave Resource, Brave on Wheels, and Brave Doctors. So the role was at the ground level, somebody would do screening, and it's a very simple idea. We come up with a very simple idea. We'd announce a helpline number, not a hotline number, helpline number, and anyone can call us if they have issue with COVID, if they were impacted by COVID, or if they think they have COVID. At that time, information wasn't that clear. In the meantime, what we were doing was I was working with two of the Nepali-speaking physicians, and I was creating videos, hours and hours of videos saying how it is developing, what CDC is saying, what World Health Organization is saying, and what we need to do. And we were broadcasting those videos either live or recorded videos. We are creating flyers, online flyers and content. At the same time, we started launching the Brave project. And let me go to next slide here. So as we were experimenting with this project here in Columbus, I was reaching out to leaders across the United States, the Bhutanese community leaders, more like South Asian leaders, and saying, hey, we come up with this model. It looks like it is working. Do you want to work on it or not? We have no other choice. If you want to, we'll collaborate. But they seems to be a little hesitant to jump into this project. And of course, they have their own, maybe they were working on their own projects and things like that. But I was also involved with students organizations, Bhutanese American Students Organization that I started in 2015. And I had these students across the United States who are in colleges reach out to me and say, hey, Sudarshan, we saw online that you are doing some project about the Brave. Would you mind letting us know what it is and how we can help? And I said, yeah, sure. I was trying to reach out to the community leaders. They didn't respond. So I was looking for some ways to reach out to other community members who would be able to at least jump into this project. So this student jumped in, and Cincinnati took it, and then they say it is working. This model is working. It is very efficient. And then Nashville jumped in, and they said if we wanted to do it, they began to implement it, and they say it works. We were able to help 5 families, 6 families, and then it went on and on. So at the time we realized that we may have to train. Not we may have to train. I have to train these volunteers and nurses and things like that. So by the time, like within 2 months, less than 2 months, we were running Brave projects in 12 different cities in 7 different states where there are majority Bhutanese Nepali refugee population, because we were targeting a specific language group, given that other community will do on their own. And one thing to tell you, when I was just brainstorming, doing things at my community center, at that time, other communities, the other Asian communities were already ahead of me. They already had established a helpline number. They were distributing foods and diapers and things like that. So they were way ahead of me. And I thought that, we are just left behind. So I have to catch up with my community. And that's how the project came up. And we trained over 200 volunteers at that time, over 3 hours. We have 58 nurses all together. We train them for what is COVID, how do you address COVID, COVID screening, all those kind of healthcare. And then to our volunteers, we were giving them 3 hours of training. One was what is privacy, because you are dealing with someone who is potentially in a COVID situation. They may need healthcare help. So you may be helping them just to provide translation or talking about resources, but you need to know what is privacy. So we give them privacy training, accountability training, and more importantly, we said this is a healthcare issue. Although it does not apply to you, we are not asking their personal healthcare information, but be aware that HIPAA applies, and this is the HIPAA. So everybody agreed, and the nurses would always be agreed, right? Because they are licensed in the state, so they would. But at the same time, we weren't asking any personal information like social security or date of birth or insurance or anything like that. We are asking them, what is your name? What is your address? So we were providing training to volunteers and nurses, and then new students, new volunteers, especially the young community leaders who are joining the project, and it became sort of a movement. And all majority Bhutanese population, we were able to cover majority of the Bhutanese population in 12 different cities, where a majority of them live here in Ohio, Pennsylvania, New York, and other southern states. So at that time, we were able to provide them training, and they were able to reach out. But also, we thought that at the time we were mostly doing all the work to the Excel sheet, and Excel sheet wasn't that helpful. Although it was helpful, but also we thought that potentially Excel sheet could expose some private information, even if we are collecting private information. So we need to come up with something that would help volunteers to really do the work from wherever they are. Most of our volunteers are students or working professionals or, those kind of things, or they're at home because of the college wasn't the break. So I reached out to my communities, leaders, not leaders, these are young students who are in college doing IT things, and I asked them, will you be able to develop me an app? And they said, yes, I will be able to do. What do you want? And then I discussed with them. So in about 2 weeks, they put together 350 hours. 6 of the volunteers, they were tirelessly working and come up with the app, which is you can even download today, although you won't be able to log inside it because it requires authentication, and we really wanted to know, and it's in-person authentication. But you can download the Brave app, which is available on Apple Store. So with that, it really accelerated our work, and we were training volunteers and then giving them this tool, and they can download this app, and then they could play different roles. And according to their own role, I don't have time to go into the detail, but they would play specific roles. A person, let me simplify this. It's very easy. Somebody would call, and when somebody calls, you pick up a call and say, what do you need? And we're trying to determine 2 things. Are you impacted because of the COVID and you need resources like food, groceries, and PPE supplies? Or do you need medical help? Just 2 information. If they need medical help, we'll forward that to medical line, and nurses will take care of that. If they need resources, they'll forward to the resource line. And then people in the resource will again call them back and then determine what they need. So whatever they may need, let's say they need rice, some vegetables, and they need PPE, then it will be dispatched to the Brave on Wheel, which is the drivers. So one of the driver will get a notification. Whoever gets the notification, it's more like the Uber, and that person will come to community center, pick up the supplies, and go drop to the family. That's it. So that's the whole model how it was implemented, and we were able to really play as a catalyst. I don't think. I don't want to claim that we were able to save lives. That's beyond what we can do. But what we did was we provided hope to the community. But at the same time, also I needed funding, right? And I began to work. So when I trained my volunteers and my staff members to take care of it, and I said, okay, let me focus my time doing some fundraising. I wrote some smaller grants to the Columbus Foundation, United Way of Central Ohio here, and then I was getting smaller money here and there. And ultimately, throughout this project that I take a record of it, we were able to raise more than $100,000, which is a very small community, very small organization, but that's a big amount. And 25% was fundraising. People were writing checks. They were coming here and dropping money and saying, you're doing good work, we wanted to support you. And 75% was more like grants. And then an unaccounted amount, which we haven't even done today, was in-kind donation. People were donating rice, lentil soups. So I was talking about the funding. So we were able to generate funding, and we were helping in different cities. Altogether, in Columbus alone, we were able to help directly by doing Kobit screening and providing PPEs, providing groceries, helping them with one-time bill payment up to $200, or if they are really vulnerable and needy, paying rent up to $500. That number of family is 411 as of now, and it's still going on. We are helping families who are really vulnerable to pay rent up to $500, and other families who are COVID impacted and didn't get the money in time or had other hardship. We were helping them at least pay bill $200 one time. And every city could not do that because they may not have a funding. Funding are oftentimes, geographically restricted. Funding in Columbus cannot go to Cincinnati, but Cincinnati also got some grants. Cleveland also got some grants. Likewise, Nashville also got some grants. So depending on what money they got, they were able to provide grocery help. PPE is universal. Anyone who was tested positive say that I'm tested positive, my family's tested positive. The next day we would try to drop PPE and PPE, Tylenol, and then we would follow. Do you need grocery? And then we'd follow. Do you need help with unemployment application? We were doing unemployment application, Medicaid applications, and then the list goes on and on. So amazing amount of work because these volunteers were really dedicated, really committed, and they wanted to protect this community. And also, it's a very tight-knit community. We have gone through a very difficult time. We have gone through a very difficult past, and helping each other has been the motto. And we were able to raise that. Although this the students and the young professionals were very young in camp to have experienced that. But somehow it was in the back of their mind that, they were able to come together and then say, this is a critical time. We really wanted to support our community. Now, cases are down, right? And we can see that there are many other places that they can go. They can get the information from other places as well. Hospitals are now jumping in, and they are providing all kind of support. So it got diversified, which is a great thing. We wanted it to be diversified, and that is helping these communities to get resources. But still today, we are working actively here in Columbus, providing support and trying to reach out to as many families as possible. And this has been one of the projects that where community overwhelmingly come together to play that role as a catalyst and not to give up the hope. I think one of the messages that I wanted to send is, if we had done similar thing in other communities too, we would have done really amazing job in terms of addressing COVID. And what my experience was, we needed a key piece of information and making people aware what is right and what is wrong. And even today, if I think that if every community would jump in, and there could be a local-based community, geographical-based community, or ethnic-based community, or church-based community, whatever it is, but if community would jump together, we would be able to address COVID more effectively than what we are doing today. Sorry, my PowerPoint went on and off, but here's this BRAVE model that I was talking earlier, and you can see the Columbus Foundation, because they gave the first $18,000 for this project, and that's where the project kick-started. And I need more time, of course, to explain and go through how this BRAVE model actually works. And it has been tested, and it really did work at the time. And I'm pretty sure this can be implemented in many ways, not only for the COVID, but we can implement this for mental health or any sort of healthcare crisis. I'm pretty sure we can implement this BRAVE, the model itself. If I have the last 1 minute, is the why BRAVE? Because it really matters that when there is a crisis, everybody needs to act. We should not wait for government or some other agencies to come and help us. We really have the ability and power to do that, but at the same time, government or the other agencies need to support and provide that critical support to a smaller and vulnerable community like mine, which is very much refugee-led, of first generation, very recently resettled in the United States as one of the highly vulnerable community. But we have shown an example that even when you are very vulnerable, you have the ability to make a difference. And really, if we have gotten other help, critical help and information, we could have even extended our help to other communities. With that said, actually, we were able to provide support to, in a smaller number, to Somali, Latino, and other Middle East Arab population as well, who were in our proximity and who were known about our projects. But although we didn't advertise to them extensively, but they knew somehow they were connected with us. So with that said, I really wanted to conclude, and thank you for listening to me, and I would be more than happy for any questions and answers. Thank you.